Now it's my pleasure to introduce our next speaker, Dr. Chris Dandoy, who's visiting us from Cincinnati Children's, where he is an associate professor in the Department of Pediatrics. Dr. Dandoy is the Director of Patient Safety and Quality in the Division of Bone Marrow Transplant and Cellular Therapies, where he's led many QI projects and clinical research endeavors. And he's also the physician lead for autologous stem cell transplant. And he's here to talk to us today about thrombotic microangiopathy and veno-occlusive disease in BMT patients. Welcome.
Thank you. Okay, can you hear me okay? Does this work? Perfect. Okay, very good. I'm going to speak a little bit today about stem cell transplant-associated thrombotic microangiopathy. A lot of words there. We'll just say it's TMA, and veno-occlusive disease, we'll just say that's VOD from here on out, if that's okay. All right. This is new. I don't have any disclosures. So what is thrombotic microangiopathy? What are we talking about here? Think of it as similar to atypical HUS. Thrombotic microangiopathy occurs in transplant patients, as well as some oncology diagnoses through a couple of multifactorial kind of hits, you could say, to the endothelium. So whether it's radiation, or whether it's chemotherapy, or an infection, or graft versus host disease, or any of the other millions of things that we do to our calcineurin inhibitors, any of the other things that we do to our patients, what happens is you get a hyper inflammatory state, and then you have activation and hyperactivation of the complement system. And when the complement system hyperactivates, it causes a lot of problems. And so really, sometimes you can have a genetic predisposition. Maybe it's just a chemotherapy and radiation, and then you develop this endothelial injury, complement's activated, and then it propagates. So TMA is a problem. And you can see here, it affects outcomes. This is non-relapse mortality. If you develop TMA after stem cell transplant, that's a bad thing. It's widely known to be associated with poor outcomes. And what do we do about it, and why do we care? Well, for the patients that develop high-risk disease, those that have organ injury and they demonstrate proteinuria, and then also show signs of hyper or complement activation, their overall survival after transplant is 16%. So this is, when you look at the survival in stem cell transplant and you read about non-relapse mortality, and they say died of respiratory failure or multi-organ injury or something like that, most of the time TMA was the driver of the whole thing. Okay, so there's two ways to diagnose it. One is from pathology, right? So you get a biopsy of a kidney or lungs, or you look for signs and symptoms in the periphery. So you look at markers associated with TMA. And so LDH is one, so LDH being high, schistocytes on the peripheral blood smear. This is a little bit tricky. For my hematologist here, how often do they count schistocytes, right? On the automatic thing, sometimes, but not really, right? They kind of do, but not all the time. So if you're suspecting it, if you have a high LDH and you're seeing that you're given a lot of transfusions, you have to suspect and you have to go look at the slides. De novo thrombocytopenia or anemia, and this is a very different thing. This isn't talking about the kids that need transfusions because they're aplastic after chemotherapy or radiation. These kids are requiring, they're requiring, either platelet continuous infusions or multiple platelet transfusions just to keep their platelets up, right, again, over that period of time. That's what we're talking about. And then proteinuria. Proteinuria is a big deal, and patients going into transplant shouldn't have it. And the proteinuria is really caused by injury to the kidneys, and then you just start leaking protein. And then also terminal complement activation. So activation of the complement is kind of how you diagnose it. So you need to make sure the ADAM TS13 is normal or above 10, and to get TTP off the plate, and then there's some other things, but creatinine doesn't really work. Haptoglobin doesn't really work as either. It can be poor prognosis, but it doesn't matter too terribly much. But those are the two ways of suspecting this. We just came up with some modified criteria. This is endorsed by all of the national bodies, EBMT, ASTCT, all of these four-letter acronyms. But it's basically the same thing. You have refractory thrombocytopenia or anemia. You're showing signs of red cell or platelet destruction. You have end organ injury, and you're showing proteinuria, and you have activated complement. That meets diagnostic criteria, but the problem is TMA affects so many organs. So TMA is associated with steroid refractory GVHD. And I need to know who's in my audience. Is everybody in the room, anybody not in hematology, oncology in the room? Where do you folks work?
GI, nephrology.
This is perfect. This is perfect. Right? Because I've got a big kidney part and I got a big GI part, and primary care, they're stuck in the hospital. Yeah, they're ruining our healthcare costs. That's what they're doing. They're in here. But they will be coming back to you. They're going to come back to you, and they're going to have hypertension issues, and they're going to have nephrotic syndrome, maybe a little pulmonary hypertension, you don't know, but these are complex patients when they come out the other side. Okay, but here's all the stuff that can happen. So, and again, this can happen with just oncology patients as well. It's not common, but it definitely can. We've had patients with rhabdomyosarcoma on the oncology service that have developed TMA. We've had patients with AML upon initial diagnosis. We diagnose the AML, they're in big trouble, TMA's happening, and we need to help calm down their complement levels. So this can happen outside of transplant in the hem-onc world. Okay, and then from a nephrology standpoint, atypical HUS is that's what they do. So, brain, you can get strokes, seizures, and press. These are all secondary to significant hypertension. Eyes, you can develop retinitis. Kidneys, renal injury, renal failure, nephrotic syndrome, and severe refractory hypertension. Gastrointestinal, liver injury, sometimes. You can get terrible ascites, GI bleeding, and abdominal pain. In the lungs, pulmonary hypertension, pleuritis, pleural effusions, heart, pericardial effusion, again with the pulmonary hypertension, pericarditis, and then anemia and thrombocytopenia. So about all the organs. Okay, so I'm going to back up here. How we found out about TMA was on autopsy. We had a bunch of kids die, and we were like, what is going on with these kids? And we had them die. We had a cohort of patients that died from pulmonary hypertension, some neuroblastomas, and some ALL kids. And the parents, we went to the parents, this was back in 2012, 2013, 14, when I was in fellowship, and we went to the families and said, we don't know, you developed this pulmonary hypertension and this is unusual. This would be helpful for our medical field to understand what was happening. And when we did the autopsy, we found signs of not only pulmonary hypertension, but also signs of TMA, and we said, that's weird, and at the same time, we're looking at kidneys. And we said, hey, what's going on with the kidneys in these kids that have this proteinuria and refractory hypertension? And TMA had been talked about and discussed, but it was said it's very, very, very rare. But we're seeing these signs and symptoms on a regular basis. So then what did we do? We did a prospective study, just catching biomarkers or catching labs. We got urine and blood on patients on a weekly basis through transplant. And then we saw, hey, you know what? Not only is TMA happening, back. Not only is TMA happening, but also it's bad. So this was from prospective screening. And then we took those blood samples and we were able to figure out markers associated with poor prognosis. So that's how these data came about. So now we're talking 2014, 2015, 2016, and we're presenting our data and we're talking about the pulmonary hypertension, how to screen for it. We're talking about pericardial effusions. We're talking about bloodstream infections ad nauseum. Think about it, if you're getting microinfarcts from GI injury from TMA, the vasculature in the gut is sealing off, you're going to have necrotic bowel and you're going to get bloodstream infections. That's just what's going to happen. And so we started to see these correlations and associations. So we would go to these meetings and we'd say, hey, this TMA thing's real. And they're like, yeah, it's real in Cincinnati, not so much anywhere else. We don't have it. And we're like, well, but they promise it's there, and they're like, I don't know. So we said, okay. So I went to Polisi and PTCTC, the Pediatric Transplant Cellular Therapy Consortium. But Polisi, if our PICU friends are in here, they're heavily involved in it. And it really is, these are two groups that are very clinically focused. And we said, hey, we think TMA is happening. Let's try to figure out what's going on, and outside of Cincinnati. And so we didn't have any money, and besides going through an R01 and trying to get funding, and it's just a nightmare. Like, it's years, and we said we could do this quickly. So we hypothesized that it's common, but we didn't know what, and then we wanted to figure out, oops, I'm not used to this one. We wanted to figure out what's the incidence, risk factors, and outcomes, TMA. And so what we did was we asked centers just to screen. Take these standard recommendations, screen for LDH, look for proteinuria. So the new labs are LDH on a weekly basis through the first 30 days, and then look at urine protein to creatinine, spot urine protein to creatinine ratios on a weekly basis as well. And then just pay attention to the blood pressure, and then have whatever either the 95th or 99th percentile, just pay attention to it, because people weren't paying attention. And we all do that, right? So they implemented TMA screening, and then we did this for about a year and a half, and then we did a retrospective analysis of the data. So we didn't have any money. The implementation was what was recommended screening, so this was published, recommended screening, and then again, went backwards and did a retrospective review. And then we assessed outcomes. Here's the requirements: daily screening, CBC, renal, blood pressure while they're inpatient, LDH twice weekly, and then urine protein to creatinine, spot urine protein to creatinine ratio weekly. And then if you showed signs of TMA, centers agreed to look at complement activation level. And then same criteria we just talked about. Okay. And then what was important is these had to concur, to meet diagnostic criteria of TMA, not only did you have to have 4 of the 7 criteria or pathologic biopsy shown TMA, you had to have 4 of the 7 criteria, but it had to happen concurrently, and it had to happen on 2 separate occasions. So there, you just had to have it. Okay, and then we did a retrospective review. So we're sitting around, we're talking folks into it. I'm a salesman, and we got 13 centers to do it, and it was great. And so they started screening for TMA, and it was great. And then what we got is 614 patients were screened. 13 centers participated, and TMA was diagnosed at a median of 22 days post-transplant, and it was diagnosed in 98 of the 614 patients, roughly 17-18%. 58, and we didn't tell people what to do with the information. If you diagnose, do whatever. We are assessing incidence and outcomes. So 58 of the 98 received TMA, received eculizumab or some other sort of therapy. We saw a significant association of TMA with steroid refractory graft versus host disease, not just grade 1 and 2 GVHD, but grades 3 and 4 GVHD. And I'm not going to go into, I'll go into a little bit, but these are the patients. Who's here taking care of an allogeneic transplant patient, right? Okay, we know this. And was anyone practicing 10, 15 years ago? Raise your hand if you were doing allo transplants 10, 15 years ago, and you know what those patients, I'm talking about terrible GI GVHD, they are in pain, lots of pain, they're on the Dilaudid PCA going nuts with it, and they're bleeding, and it's just continuous bleeding and pain. And what we found in our research that that's TMA and GVHD. Okay, but we'll go over that in just a second. So here are the outcomes we looked at, and then we just compared TMA to no TMA. So you can see here, respiratory failure requiring intubation, non-invasive ventilation, pericardial effusions requiring a drain or a window, 10% versus less than 1%. Pleural effusions requiring pleurocentesis or chest tubes, pulmonary hypertension, and it's real deal pulmonary hypertension. Needing to go on CRT, 15% versus 3% in the first 100 days. Acute kidney injury, PRESS, hemorrhagic cystitis, and pulmonary hemorrhage. And then when we looked at odds ratios, these are all poor outcomes, and the odds ratios are all over to the right-hand side of the one, including transplant-related mortality and death. And we looked at other things. So ICU days, hospitalization and ICU days in the first 100 days post-transplant are much higher. So if you get TMA, you're going to be in the hospital about 70 days versus those without it had hospitalizations of 40 days. And the same thing with ICU, much, much higher. And then same thing with bloodstream infections, much, 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 much higher. And then 6-month overall survival is much lower. So TMA is bad. And it's getting, so we say there, it's underdiagnosed too. You've got to screen for it, you've got to look for it. So it's a multivisceral disease, and it requires a multidisciplinary approach. So you need to have radiology, you need to have cardiology. I don't have GI, and oh, there you are, bottom right, perfect. I was like, oh no, I started panicking. Cardiology, nephrology, GI, pulmonology, infectious disease, you need to have everybody. So let's go through a couple. Importantly, intestinal TMA. And this is where you need to involve your pathologist. When a pathologist when they get the biopsy samples for acute graft versus host disease assessments, rarely do they look at the vasculature. They look at the mucosa. And a lot of the statements are on the mucosa, but it's the vasculature that's a problem. So how do these kids present? And these kids, so then you say, how do you know it's not just GVHD? Because neuroblastomas get it. And they get this terrible, terrible abdominal pain that's bleeding all over the place. And they have an autograft. So it's not graft versus host disease, and it's concurrent. So severe pain, ileus, signs of an ileus, mucosal erosions, hemorrhages, and then you can develop these bowel strictures from TMA as well. This is a little bit of what the bowel looks like under microscopy in patients with TMA. So you have loss of, and you can see up here in the top right is where the pathologists are, see? The pathologists are looking top right over in the mucosa. When you look in the vasculature is where you start to see signs of TMA. So you'll have schistocytes, red cells being squoze into the peripheral, into the tissue. You'll have intraluminal fibrin. You'll have endothelial cell swelling. All of these, and loss of glands, and all of these are signs and symptoms or pathological evidence of TMA. And here's some other schistocytes, fibrinoid debris, microthrombi, and endothelial swelling and separation. And this is just another patient. Now, what about in the kidneys? Same type of thing, but they present when they have TMA with significant hypertension, nephrotic syndrome, AKI, and renal failure. This is different than acute glomerulonephritis. This is different than other things that cause kidney injury. But when you see signs and symptoms of TMA and you see the nephrotic syndrome, that's what's driving it. And then over time, they'll have, and creatinine's not the way to follow it and follow improvement because creatinine takes a little bit to catch up. But usually we follow hypertension management or control, being able to have stable hypertension and coming off of the medicine as a sign of improvement and improvement of the proteinuria. A lot of the CNS issues are because of the hypertension, because we weren't watching it closely. And patients were, like this kid right here that bled, they probably had a systolic of 160 or something. It was a 3-year-old. And we were thinking we were gonna, but you guys know on the floor, you say, oh, we'll give a PRN and we'll see how it does with this new amlodipine and if it gets better, and you drag your feet a little bit and then all of a sudden you're in real trouble. So aggressive hypertension management is important. Going back to pulmonary TMA, so this has been called a number of things, pulmonary VOD, pulmonary interstitial nephritis, and you can still get idiopathic pneumonitis syndrome. That's a whole other thing, but pulmonary TMA really drives pulmonary hypertension. And then we found this starts as early in patients with TMA as day 7 post-transplant. So if you have a patient with unexplained hypoxemia, clear lungs on x-ray, they don't have big masses or anything, drop in hemoglobin, fast progression to ARDS, they respond to nitric oxide, then you really need to think of pulmonary hypertension secondary to TMA. Now here's the thing, And I'll speak about this on you screen with echoes, but if you're not looking at the RV, the right ventricular pressures, and trying to estimate it, sometimes you don't get that. And if you're reading it, if we're reading it as clinicians, and it doesn't say blatantly pulmonary hypertension is suspected, it's tough to pick. So when you're putting your orders in, if you suspect it, you need to say, please evaluate for pulmonary hypertension in your echo ordering. And pericardial effusions, they can be terrible. And we look retrospectively at patients with TMA, and 70% of them develop at least a small to moderate pericardial effusion, with about 10% getting all the way to tamponade. So problem. We did and this is a sidebar because I knew I'd have some ICU friends here. We do screening on all patients that come to the PICU. We do an echo. And then if there's any acute changes in status, we do another echo. Again, looking for pulmonary hypertension. And this is what we've seen. This Venn diagram goes over, I apologize, you're not able to see it because it's so tiny, but this is the paper. But the circles are moderate to large pericardial effusion on the right, left ventricular systolic dysfunction, that's going to be, sepsis stuff, and then elevated right ventricular pressure. And in the 70 or so, 86 patients, we saw signs of elevated RV pressure in 24, with the Venn diagram having some pericardial effusions and some LV dysfunction. But then we broke it down. Oh, did I break it down? Nope. We broke it down a little bit more, and the pulmonary hypertension were in the TMA patients, the pericardial effusions were in the TMA patients, but the LV dysfunction were all completely septics and shock and that kind of thing, unless they had right ventricular compromise. Okay, this is just an instance. Patient with TMA had worsening hypoxemia, got worse and worse. We started sildenafil and eculizumab on roughly day 40 and seemed to improve. With this pulmonary hypertension, we've done multiple atrial septostomies that have worked just fine, and those patients are able to recover and improve. But it happens. And then this slide here just kind of goes over our assessment when to think about pulmonary hypertension. Again, if you're suspicious, they have a new O2 requirement, it's a good idea to get it. So going back to the GI-GVHD thing. GI-GVHD, ST2 is a marker, can be a marker of endothelial injury. It's used in the cardiac world quite a bit for cardiac function. But there was a link published in New England Journal years ago that in 2017 that said this ST2 is associated with mortality post-transplant as well as graft versus host disease. We said, this is crazy, this is great. And then we looked, and this is their data here. And so elevation of ST2 days after transplant, both in reduced intensity conditioning and myeloablative conditioning. If it was elevated, it was associated with poor outcomes. And so we had this, we were sitting there in the middle of this concern about, is this really TMA that's driving it? And we found, oh, I'm so sorry, I'm not used to this. We also found that ST2, this endothelial injury, not only is associated with non-relapse mortality, but in reality, it's GVHD and TMA. It's these high-risk GVHD patients that also have concurrent TMA, and that's what's causing, it's not the GVHD, it's the TMA that's the problem. And so addressing it can improve these outcomes. So what do we do? So eculizumab is super expensive. It's a cheap 2-year-old car every time you infuse it. 12 to 16, 17,000 bucks an infusion. Terrible. There are other pharmaceutical companies that are making it. At some point, hopefully, it will go generic and be cheaper, but it's not. It's expensive. So you don't want to overtreat TMA, but you also, on the other side, you got to get it because if you don't treat it, they're going to die. And we've developed, if you are high risk, and this algorithm is going to be right here, so you guys will have it. But really what we're saying is, when you break it down, you have a high-risk group. High-risk group that develop multi-organ dysfunction, have the elevated, have proteinuria, elevated complement. This is a high-risk group. A moderate risk group may have elevated complement or have proteinuria, but don't have both. They have overall survival of 71, so still pretty low. And then those that have the other markers of TMA but don't have elevated complement or proteinuria, those without any therapy have a 94% overall survival. And this goes over a little bit of, it is so expensive. So in patients with TMA, we looked at the cost. And again, this is a multi-center study. Patients in red have a much lower overall survival. The blue, they survive at a higher rate. But then what we want to do is cost per day of the TMA patients that received eculizumab and those that didn't receive eculizumab. And remembering that you're going to have prolonged hospitalizations without treatment and also increased supportive care. And the only time that eculizumab was significant, the eculizumab group was higher than the non-eculizumab group is when you had GI GVHD and TMA and you had GI bleeding. Because in those patients, you have to give higher doses and they require more infusions and it's a lot of cost. Okay, so this is a little algorithm on who to treat, who not to treat. Again, high risk should go into it, and then you have kind of a stepwise approach in moderate risk. And as you guys in the next few years, we'll probably be looking at this and using this possibly a little bit more. So what do we see? This was just recently, we just published this a couple months ago. We did a prospective interventional study with eculizumab, and we saw, and then we compared the outcomes to historical controls. And we saw that eculizumab patient survival, if you treat these high-risk patients, their survival is about 70%, which is up from the 18% that we saw in the past. This just goes over the study a little bit. This goes over eculizumab as if you have GI bleeding, you have to dose it more frequently. Okay, so big story on the TMA and eculizumab. Hopefully, you just got to recognize it early, treat it in high-risk patients, do screening for it, look for it, understand it's there, and then know that hopefully in the future there's going to be other mechanisms to treat it. And then we will transition from TMA to VOD. Okay, so here we go with VOD. This one's a whole other scenario. These are tricky questions that don't have necessarily a right answer. I want to get everybody's participation in this and your thoughts and shouts and tell us what you think. Okay, 16-year-old male being treated for ALL, CR2, fully matched SIB donor, TBI-Psi, PrEP, GVHD prophylaxis, cyclosporin methotrexate. He got ursodiol for VOD prophylaxis. I hope you can see this. I'm going to go through it because it's too small. Day 15 is here, day 10. So here you have a normal creatinine. All of a sudden the creatinine's 2.3 from 0.5, and the kid's hypotensive. And your Billy, your total Billy 6.4, your INR went from 0.1, that's not real, 1 to 3.5, and now your ALT is 412, and your ammonia is elevated, and you show reversal flow in the portal system. Okay, so here's your clinical presentation. This is one of those kids that you walk in the room and you're like, oh, you got VOD. Right? I know what this is. And then you're talking to the residents. You're like, hey, you need to go in that room and see what VOD looks like, because that's it. And then the echo is like, oh, or the ultrasound shows, oh, you got some VOD here. So does the patient have VOD? Probably, right? Yeah, okay. So what VOD targeted therapy would you start? So options are defibrotide alone. Second option is steroids alone. Third is defibrotide and high-dose steroids, or nothing. So let's go through. A, raise your hand. B, raise your hand. C, raise your hand. D.
A lot of people didn't vote.
That's okay. That's okay. But this is a discussion because in practice, there's a lot of variation in practice with VOD. So Mitch Cairo, who's in New York, he loves VOD. He talks about it. Anytime you're at a meeting, Mitch is probably talking about VOD, right? He doesn't believe in steroids. We are a steroid center, so we do both. We start defibrotide, and then we give them 500 milligrams per meter squared of methylpred given twice a day. So we give them a slug of steroids. Slug. Okay, so that's what we do, but some places they don't. Another option, this kid has a big taut abdomen. Do you put in a peritoneal drain? Raise your hand if you put in a peritoneal drain. Right? We don't do peritoneal drains, but Philadelphia does peritoneal drains on everybody, and Atlanta does peritoneal drains. So there's variation, but we never do. Never. So there's some variation in practice, and as we go through this, we'll see that there's some different ways to approach it. Okay. Okay, so remember, we're hypotensive. We're probably in renal failure with a creatinine of 2.3. Where's our coags? I'm sure our coags are all broken as well. They're not up here, but what would we give here? Everybody go with D? Everything? Yeah, everything, right? You're going to get inotropic support, probably start some CRT. This is tricky. So the worst thing and I can't speak for my intensivists, but if a patient for sure is going to be going on and needing dialysis, it's probably a good idea to get the dialysis line sooner rather than later. So as these kids are progressing and they're not improving, and you just get the silly pheresis line so you can start dialysis. Otherwise, it's going to be a pain. It's going to be a pain. Oh, would you alter his calcineurin inhibitor? Raise your hand. Who would not? Who would? I would just follow levels. Keep it on the lower side, but you're not that far in, right? You're only like 15, 16 days. This is so again, variation in practice. Some people would cut it. I think Mike Grimley would stop it, but I would be a little bit more, I'd drag my feet a little bit more. So these are, again, thought-provoking, no right answer, except for this one. Okay. So, patient got high-dose steroids, started defibrotide. Our Billy's getting better, kind of, not really. And then we finish it. We did high-dose steroids for 3 days. Then we did 21 days of defibrotide. And how do we diagnose it? This is the EBMT criteria. So we have unexplained consumptive and transfusion refractory thrombocytopenia, otherwise unexplained weight gain on 3 consecutive days, hepatomegaly, ascites, rising bilirubin. There you go. So EBMT criteria. And I don't see reversal flow in there on the ultrasound, but that should be in there as well. Supportive care should be aggressive fluid management. And I think the aggressive fluid management should start way before. Sometimes we let our patients, as they go to transplant, we let them gain weight. Have strict I's, start them on diuretics early, keep them about fluid even, and don't let them get away from it. Correct their hypernatremia, correct the coagulation and thrombocytopenia. Another thing that happens, and this is a kind of a plug, when you're giving hepatotoxic medicines, try to have no Tylenol, make it an allergy while you're giving the PrEP. We've done that, and then taking off all of the other hepatotoxic meds and making sure they can't get them, put them as allergy while they're getting it. Correct their hyperammonemia, nutrition. Defibrotide, severe cases of VOD, this is the standard of care now. You get at least 21 days. I like to keep my platelets on the higher side, around 30, and an IRNR roughly less than 2. Steroids, here's the paper. This is what we do. I think it works, but there's a little bit of voodoo magic and hand waving. Who knows? This is our single center experience. The one thing that I can tell you is those patients that are going on to develop VOD have a significant hyperinflammatory process happening. So if you're looking at just some of the markers of inflammation, IL-6, CRPs, CXCL9s we've looked at, and they are all off the charts as you're leading up to having VOD. And so that kind of goes along with the steroids of trying to decrease that inflammation. At this point, I wouldn't use targeted immunosuppressants or anti-inflammatories. I would use steroids, and that's what we do. Okay, so now the patient's encephalopathic. What's causing the encephalopathy? Ammonia is probably still high. They didn't tell us. But there's a suspected thrombus in the portal system, small ascites. Hemoglobin's low, platelets are a little low. You're still needing to give platelets quite a bit. You have some schistocytes. What else could be going on here? TMA, right? Yeah. And having these endothelial injury syndromes are on the spectrum. So you have, in the lungs, you can develop diffuse alveolar hemorrhage where you're bleeding. In the liver, you can get veno-occlusive disease. And then you have TMA, and a lot of times you'll have them both. So potentially TMA. So other endothelial injury, this could be transplant-associated thrombotic microangiopathy. We check ADAM TS13 on every patient. I have yet to see, not every patient, but every patient we suspect of TMA. I have yet to see TTP, but we should rule it out. And the encephalopathy could be a cause of a number of things. One, it could be you're still on, you haven't cleared your medicines or your drugs. You could have TMA that's affecting the CNS. You could have high ammonia. You could have a number of things, but TMA can affect the CNS as well. Okay, so here's a talk. I would like to see what people would do. What do you do with that portal venous thrombosis? You're off of defibrotide at this point. Defibratide's over. You find a portal venous thrombosis. So your options are surgical thrombectomy, systemic anticoagulation, or nothing. Yeah, raise your hand if you choose surgical. Raise your hand if you do systemic. Would you do, yeah, and I think that's, and then some people, and then raise your hand if you do nothing. Yeah. Yeah, so, and you're off of defibrotide at this time. You're off of the defibrotide, so you have this residual. And then what are the problems? What if you leave that? What is, of course, starting anticoagulation, your risk is bleeding. What is your risk of having a portal vein thrombosis? Anybody know?
It'll evolve to like splenomegaly, and you can end up
And bowel infarcts.
Yeah, portal vein hypertension.
Right, like, which is going to be a disaster for years to come. So again, comprehensive, this slide here is to show you got to get around with your team, you got to get everybody involved and talk it through of what's the best option. This is therapeutic plasma exchange. We don't do this. Do you guys do this very often anymore? What do you do? Well, you guys do it. You're hematologists. Did you do it very often in Georgia? Yeah, we don't do it too terribly often either. We do it to clear. We do it for some other reasons. Autoantibodies when we're trying to get rid of stuff. But okay, so in summary, incidence of TMA is likely underestimated. Prospective monitoring for TMA is indicated. LDH elevation, proteinuria, hypertension, suspect TMA. Please watch your hypertension. Please watch your blood pressures. Look at activated terminal complement. Organ-specific tests should be included. And then when you have your path samples sent down to pathology, please make sure to just have them look at the vasculature as well. In patients that have high-risk TMA, consider treatment. Early recognition and treatment and management of VOD is important, and that includes aggressive fluid management, defibrotide, and steroids. And I will take any questions. Yes, ma'am.
But I want to know why. Why did this happen? Why is this happening? What did we do to turn off the surveillance of the Is it the NK cells? Why did we turn off something that was controlling the complement system, and the complement system went crazy?
Because we ablated them. We basically killed them, and now we're trying to save them with a graft. So there's a couple of things here. One is genetic susceptibility. We looked at, we looked at about 200 patients consecutively, and we looked at SNPs associated with atypical HUS. So these polymorphisms that can develop hemolytic uremic syndrome. And we looked at those in patients that developed TMA and those that didn't develop TMA. And we saw that patients that did develop TMA had a whole bunch more of these SNPs, these HUS SNPs. And then we looked at the African American population because it was more of a hunch. There seems to be more African Americans developing TMA versus those that aren't. And in the African American population, they had a higher rate of these polymorphisms as well. So that's interesting. So potential hypotheses, why? Our suspicion is it's the meningitis belt. So this was elected for thousands of years ago for people in the meningitis belt. And so when you have meningitis or you get meningitis, complement is the way to fight it. And so you have a lower threshold to have complement activated. Okay, having complement activated is not a bad thing. We have complement activated all the time when we get infections. It helps do a lot of different things, but it's when it's just out of proportion and blown out, it's gone too far. So you could have a genetic predisposition for it. And then two, it's compounding. So chemotherapy and radiation is the biggest trigger. And then on top of that, there are a few viruses, adenovirus, BK virus, CMV virus that can propagate it. And then again, what happens is the activation, hyperactivation of complement. Calcineurin inhibitors are known to cause it. So that could be your second hit. And then other predisposition type stuff. There's a couple of other populations that really do get this, and it's the immune deficiency patients that have had a lot of different infections. And what I mean by that is they're just fragile. These are the CGD patients, and they seem to develop it. Or maybe some of the HLH patients, they seem to get it, and these lymphoproliferative disorder patients get it. What I didn't show you is 25% of neuroblastoma patients get it. And it's real, and it happens. And if you don't get on top of it early, then they'll go into renal failure, and they'll be on dialysis. But if you jump on it early and slow it down, then they'll be okay. They'll turn it around.
I know, so creatinine, not a great marker for these patients for kidney injury. And I know, a ton of work has been done on NGAL at Cincinnati especially, and with the cardiac surgery patients. Have you guys looked at that marker for this population or
We have,
others?
and we have, and it was the same as just kidney injury, but we couldn't predict off of it. Yeah, not as good as just proteinuria was as effective, and it's definitely cheaper.
Thanks. So, Chris, you talked about steroids, the 48, 72-hour steroid, which I know. So when we were in Arkansas, so we had a cluster of VOD, and when we talked, and this was something we started doing it. But I mean, obviously this is sort of very institution-specific, institutional experience, which not everybody sort of practices. So the question that always comes up is, yes, we can certainly start it. We have to rule out infections, EBV, CMV, and all those things. And some of those infections and viral PCRs are not going to be back for maybe 2 days or so at most of the places. And then you are also losing the window during that period of time. Hence, that we are a little bit reluctant to start VOD. So in that situation, I mean, what else we could possibly do to
You're
actually
100% right. And so it should be thoughtful on, especially if we have a mismatch or a haplo. But your autos don't get these infections. They don't get CMV, adeno, or fungal infections. They get bacterial infections about 10% of the time. But you're right. If you have and we look at that. There are some patients that we would hold off. What if you have a kind of a crappy cord or something? You would think twice about it a little bit.
I have a question about duration of therapy for defibrotide. So currently the FDA label says 21 days, and I think 21 days is what you do. We did have a patient in the last year or so that got pretty obvious VOD, well, very obvious VOD after thioguanine for ALL treatment. And he seemed to be a super responder to defibrotide 2 days later. And I found a case series that suggested some data that you could stop it early. Is that a practice other places?
I do
Okay.
too. Yeah. It depends on the scenario. If they're on their last transplant and they recover really quickly, I would stop it at 14 days. I have to do it quietly, though, because not all of my colleagues agree with me. Yeah, variation in care. The other thing I wanted to point out specifically to junior faculty is the mechanism. When I talked through that study, that mechanism's real, this pragmatic approach to research studies. So if you thought about how that would happen in an R01, you'd put in a proposal in January, you probably wouldn't get funded, but they would tell you over the summer, so you put it again in the fall, and then let's say you get funded, your money would probably come March or April, then you'd set this up next year, then you'd set it up with the institutions. Now all of a sudden you're 2 years after your idea. If it's implementation of known practices, that's a way to do these types of studies. VOD is uncommon. And that's why Polisi and some of these other groups, PT-CTC, is a good place to look and get friends together to try to answer questions that are rare. Hemorrhagic cystitis is another, very rare, but again, partner up with your friends and try to understand what's happening can happen. And you can do it on a cheap basis. You just got to make sure to include everybody on your papers.
Any other questions?
Your talk brought up some PTSD from me when I was a nurse caring for transplant patients, and
You miss it.
have-
It's amazing.
not after that talk. So
But they get better. I promise it's better now. I promise.
well, I've been telling myself
I haven't
that.
seen, you remember the terrible skin GVH? I haven't seen that for 5 years.
Well, I can show you some pictures on
Knock
my
on wood.
phone from yesterday. but I know you said it's underreported. Can you just remind me that this is not as common, and we're going to have a lot of transplant patients that have a smooth course
Yeah.
and do well?
Yes, and the more you do, the more like you're able to walk in the room, you're gonna be like, oh, you got VOD, but it'll be okay. I have a patient right now, neuroblastoma patient, he's day 11, day 7, everything started to have low-level bilirubin, kind of ultrasound that day. He wasn't holding on to fluid. His fluid status was fine. His abdomen was diffusely tender, but not like that kid where you walk in the room. And then within 48 hours, Billy went up, reversal flow, had TMA signs as well, so we started everything. And within 24 hours, he's starting to recover, right? Like today, when I looked at his labs this morning, he's fine. He'll be fine. It does. And the other part, too, is we've come along, how long ago were you in the BMT unit? Okay, so adenovirus was a big deal back then. CMV really was a big deal back then. It's not as much anymore. Patients die of CMV and adeno, but not nearly like they used to. Busulfan kinetics. So does everybody know what that is? Busulfan kinetics has really revolutionized kind of our field. And then tighter control of their GVHD prophy meds. It's just different. So now kids go through transplant and it's much happier. And the ones that are going to have a hard time, everyone knows that they're going to have a hard time coming in. And those are tricky. And then you guys think about, want them to go to, like the super duper tricky ones. Do you want them here, or do you want to go to other place? And that's okay, you know? Tricky ones, you know what I'm talking about.
Yeah, they come back.
That's not a bad thing, because then just hugs. Then you're giving hugs and labs, and it's good. The transplant's not like it was 12 years ago. And the kids coming in and they're bleeding all over the place is not happening nearly as much. This type of stuff, these small steps we've been able to make as a field have really helped. And the skin GVH was the worst. You don't see that anymore. Knock on wood, but you don't.
One more question for Dr. Dandoy.
Hi. So I have a 7-year-old that has had horrific TMA for the past year, has had TPE, eculizumab, ruxolitinib, rituximab, is still transfusion dependent, is just still a hot mess, was in clinic yesterday, BP's 152/102. He's being treated at TCH, but he's our primary, so we see him weekly with his Houston visits. So my question for you is, how long can you treat this? And will it ever go away?
A year's a long time.
Yeah.
Yeah, but that's
But
just
he has
decides
everything else. He has all
Yeah,
the
yeah,
other
yeah, yeah.
criteria.
And then and you transfusion dependent?
Platelets and PRBCs.
Every day.
Once, at least weekly, sometimes twice a week.
And then how often are you dosing eculizumab?
They're down to once a week now. He got it twice a week for a long time while he was getting TPE at the same time.
And are you doing CH50s to follow levels?
I'm looking in his notes right now because I saw him yesterday. His last level, his CH50 last level was 13.8.
That's pretty high. He's not
and
blocked.
His SC5B9 was 175.
Yeah, but your SC5B9 can be down, but you're not adequately blocked. But the other part too is, does he need another med?
He's on lots.
Yeah.
And so I guess this is just like for me, and again, we don't do transplant here, so we send our kids away and get them back. This is the worst.
What's the
I've
underlying
seen.
diagnosis?
ALL. He had standard risk ALL.
That sucks.
Relapsed within 6 weeks off of treatment.
Will you send me an email? It would be good for.
Okay.
It'd be probably good for, like maybe we could do it like just a thing, and then we can look through the
Yeah.
logs together and kind of thing.
I mean, definitely. I mean, this is why. Well, first of all, it's just terrible.
Yeah.
And this poor family is broken. And then he comes to clinic and everybody freaks out because with transfusions, his blood pressure goes sky high. He's on 4 meds. Dave has seen him a couple times. But it just, I'm like,
sorry.
is he going to die of this? Is this what's going to kill him?
It might.
You know?
It might, and I'm sorry. But here's what we can do. And so that's another thing too.
Right.
As you guys are going through this process, know that you have friends, and you can call your friends. Like we are here. The Boston folks are lovely. CHOP folks are lovely. John Craddock in Texas is a wonderful person. Like you've got friends, and you can talk through these things.
Well, I almost think, and this family is so amazing, I feel like maybe they could use a second opinion. About
Yeah, and we could look, and so why don't you just do that? And we could have them in the same room, and we could look through their stuff together, and I could grab one of my colleagues, and we could do it all together sometime. That'd be easy.
Dr. Mion's got one more question.
Just to follow, so you talked about this high-risk patient, so prophylactic, we have defibrillatory, and it's approved, yes, no, it depends on where you are, some people use it, others don't.
Yeah, the only patients we use it for are patients that had prior VOD, or some of those that received meds that are associated with it, right? So some of the AMLs and ALLs, but that's it. We do not. Did you see the paper come out of San Francisco with the prophylactic defibrillotide? Wasn't good. It wasn't better. They still got VOD. They still got TMA. It didn't work. But I think there's still some patients that it's probably because the other thing too is what are you going to do if they get VOD?
Thank you so much, Dr. Dandoy. This is
Thanks,
great.
guys.